Hi guys, welcome back to channel The Dimensions of Anatomy. This is third in the three-part video series on the anatomy of larynx, and in this part we will be discussing mainly the muscles of larynx. The muscles of larynx include the cricothyroid, posterior cricoarytenoid, lateral cricoarytenoid, transverse arytenoid, oblique arytenoid continuing as aryepiglottic, thyroarytenoid continuing as thyroepiglottic, and vocalis. Before moving on to discuss the muscles, let's add the muscles to the diagrams we already practiced. This is our whole diagram of the cartilages of larynx, which we practiced in one of our previous videos. We will add the muscles of larynx to this. This is our cricothyroid, posterior cricoarytenoid. In order to add our next muscle, that is lateral cricoarytenoid, we will remove the thyroid cartilage altogether. And now let's add lateral cricoarytenoid. This is transverse arytenoid, thyroarytenoid continuing as thyroepiglottic muscle, let's remove transverse arytenoid and add oblique arytenoid continuing as aryepiglottic muscle. And the last one is vocalis. Okay, now that our diagram is ready, let's get back to our class. Okay, let's discuss the muscles. Like any other muscle, we will discuss these muscles also under the subtopics of origin, fibers, insertion, nerve supply, action, and clinical anatomy. Initially, we will cover origin, fibers, and insertion. We will see the origin, fibers, and insertion of each muscle separately, followed by nerve supply and action, followed by clinical anatomy. Okay, let's start. First, let's see the cricothyroid muscle. The cricothyroid muscle takes its origin from the lower border and lateral surface of cricoid cartilage. The fibers run backwards and upwards and get inserted into the inferior cornu and lower border of thyroid cartilage. Coming to posterior cricoarytenoid, the posterior cricoarytenoid takes its origin from the posterior surface of the lamina of cricoid cartilage. The fibers run upwards and laterally and gets inserted into the posterior aspect of the muscular process of arytenoid cartilage. The lateral cricoarytenoid takes its origin from the upper border of arch of the cricoid cartilage. We saw the cricothyroid takes its origin from the lower border. The lateral cricoarytenoid takes its origin from the upper border of the arch of the cricoid cartilage. The fibers run upwards and backwards and gets inserted into the anterior aspect of the muscular process of arytenoid cartilage. We saw the posterior cricoarytenoid attaches to the posterior aspect of the muscular process, whereas our lateral cricoarytenoid attaches to the anterior aspect of the muscular process. Coming to transverse arytenoid, the transverse arytenoid runs from the posterior surface of one arytenoid cartilage to the posterior surface of the other arytenoid cartilage. The fibers are transverse. Coming to oblique arytenoid, the oblique arytenoid runs from the muscular process of one arytenoid cartilage to the apex of other arytenoid cartilage. The muscular process of one arytenoid cartilage to the apex of other arytenoid cartilage. Some of the fibers of this oblique arytenoid muscle continue into the aryepiglottic fold and they are called aryepiglottic muscle. They run up to the epiglottis through the aryepiglottic fold and they are called aryepiglottic muscle. The fibers of the oblique arytenoid is oblique. Coming to thyroarytenoid, the thyroarytenoid takes its origin from the thyroid angle and adjacent part of cricothyroid ligament. It runs backwards and upwards and inserts into the anterolateral aspect of arytenoid cartilage. Some of the fibers of this thyroarytenoid continues into the aryepiglottic fold, just like our aryepiglottic muscle. Some of the fibers of this thyroarytenoid continues into the aryepiglottic fold and these fibers are called thyroepiglottic and they run up to the epiglottis. Coming to the last muscle, that is the occalis. It runs from the vocal process of the arytenoid cartilage, the fibers running forwards and inserts into the vocal ligament and thyroid angle. So it takes its origin from the vocal process and inserts into the vocal ligament and thyroid angle, the fibers running forwards and it runs through the vocal ligament. Okay, these are the muscles: the cricothyroid, posterior cricoarytenoid, transverse arytenoid, oblique arytenoid continuing as aryepiglottic, thyroarytenoid continuing as thyroepiglottic, vocalis, and the one we left is lateral cricoarytenoid. This is the posterior cricoarytenoid. This is the lateral cricoarytenoid. Okay, now we have seen the origin, fibers and insertion of all muscles. Now we'll move on to the next topic, that is the nerve supply. All the intrinsic muscles of larynx are supplied by recurrent laryngeal nerve except the cricothyroid muscle, the first muscle we saw, that is the cricothyroid muscle, which is supplied by external laryngeal nerve. So all the intrinsic muscles of larynx are supplied by a recurrent laryngeal nerve. There is only one exception, that is the cricothyroid muscle, which is supplied by external laryngeal nerve. Coming to the actions, there are 6 actions divided into 3 sets brought about by the intrinsic muscles of larynx. We will see each set separately. First, we will see the abduction and adduction of vocal cord. This is the vocal cord here. The intrinsic muscles of larynx bring about the abduction and adduction of vocal cord. Abduction refers to separation of the vocal cords, that is the 2 vocal cords moving away from each other, and adduction, adding. Okay. Adduction refers to the coming together of the vocal cords, that is the 2 vocal cords coming close together. Okay. The abduction of vocal cord is brought about by the posterior cricoarytenoid muscle. It is the lone muscle which brings about the abduction of vocal cord, that is the separation of vocal cord is brought about by one single muscle, that is the posterior cricoarytenoid, and hence it is called safety muscle of larynx, because it is the only muscle which separates the vocal cord and allows passage of air, making respiration possible. Okay. So there is only one muscle which abducts the vocal cord, and that is the posterior cricoarytenoid. Okay. This posterior cricoarytenoid is attached to the posterior aspect of the muscular process. We already saw. Yes. Okay. This posterior cricoarytenoid attached to the posterior aspect of the muscular process while contracting pulls the muscular process backwards. Okay. Pulls the muscular process backwards, thereby bringing the vocal process laterally. When the muscular process is pulled backwards, automatically the vocal process moves laterally, thereby abducting the vocal cords. Okay, the posterior cricoarytenoid pulls the muscular process backwards, moving the vocal process laterally, abducting the vocal cord. The adduction of vocal cord is brought about by 3 muscles: lateral cricoarytenoid, transverse arytenoid, and oblique arytenoid. The lateral cricoarytenoid attached to the anterior aspect of the muscular process pulls the muscular process forward, thereby moving the vocal process medially, which causes the vocal fold to, or the vocal cord to, adduct. Okay. The lateral cricoarytenoid along with transverse arytenoid and oblique arytenoid pulls the muscular process forward, moving the vocal process medially, thereby adducting the vocal cord. So abduction is brought about by posterior cricoarytenoid and adduction is brought about by lateral cricoarytenoid, transverse arytenoid and oblique arytenoid. Coming to tension and relaxation of vocal cord. Tension refers to extension of the vocal cord and relaxation refers to shortening of the vocal cord. Okay. The tension is brought about by cricothyroid, which here is referred to as tuning fork of larynx, because just like you might have seen tuning of the musical instruments. For example, a guitar is tuned by rotating the knobs which are meant to adjust the tension of the strings. Yes, the same way our vocal cords, which are responsible for the production of sound, is tuned by this cricothyroid muscle. Therefore, it is called the tuning fork of larynx. So, the tension of the vocal cord is brought about by cricothyroid muscle, and a relaxation of the vocal cord is brought about by two muscles, thyroarytenoid and vocalis. Okay. This cricothyroid here, when contracting, pulls the thyroid cartilage forwards and downwards. Okay. This cricothyroid pulls the thyroid cartilage forwards and downwards. Cricothyroid brings about forward movement of thyroid cartilage, which in turn elongates the vocal cord, bringing about tension of the vocal cord. Okay. The cricothyroid moves the thyroid cartilage forward, elongating the vocal cord, causing tension of the vocal cord. The thyroarytenoid and vocalis, they run from thyroid cartilage to the vocal process. The thyroarytenoid and vocalis pull the thyroid cartilage backwards, thereby relaxing the vocal cord. They shorten the vocal cord, thereby causing a relaxation of the vocal cord. Okay. Thyroarytenoid and vocalis pull the thyroid cartilage backwards, causing shortening of the vocal cord, producing a relaxation of the vocal cord. So, tension of the vocal cord is brought about by cricothyroid. Relaxation of the vocal cord is brought about by thyroarytenoid and vocalis. The next set is the opening and closing of the inlet of larynx. The inlet of larynx, its boundaries we already saw in the previous video. The inlet of larynx is opened by thyroepiglottic muscle and it is closed by oblique arytenoid continuing as aryepiglottic muscle. The thyroepiglottic opens the inlet of larynx and the aryepiglottic, that is the continuation of oblique arytenoid. The aryepiglottic closes the inlet of larynx. Okay, so there are 6 actions, 3 sets of actions. The abduction and adduction of vocal cord, the tension and relaxation of vocal cord, and opening and closing of inlet of larynx. The abduction of vocal cord is brought about by a single muscle, that is the posterior cricoarytenoid, called the safety muscle of larynx. The adduction of vocal cord is brought about by 3 muscles, lateral cricoarytenoid, transverse arytenoid and oblique arytenoid. Tension of vocal cord is brought about by cricothyroid muscle, called the tuning fork of larynx, and the relaxation of vocal cord is brought about by thyroarytenoid and vocalis. The opening of inlet of larynx is brought about by thyroepiglottic muscle, whereas the closing of inlet of larynx is brought about by oblique arytenoid and aryepiglottic. I think the actions of the intrinsic muscles of larynx will be better appreciated with the help of a 3D model. We have a 3D model here: epiglottis, thyroid cartilage, cricoid cartilage, and here we have the arytenoid cartilage. Now let's add the muscles to this. Here we have the cricothyroid running from the lower border of cricoid to the inferior carno and lower border of thyroid. Rotating to the posterior view, we will see the posterior cricoarytenoid running from the posterior aspect of cricoid to the posterior aspect of the muscular process of arytenoid. Now let's remove the thyroid to view the lateral cricoarytenoid. Here we have the lateral cricoarytenoid running from the upper border of cricoid to the anterior aspect of the muscular process of arytenoid. Coming back to the posterior view, this is transverse arytenoid running from one arytenoid to the other arytenoid. The oblique arytenoid running from base of one arytenoid to the apex of other arytenoid, some fibers of which are running into the airy epiglottic fold as airy epiglottic muscle. Coming to the top view, let's remove the epiglottis for a better view. Here we can see the thyroarytenoid running from the thyroid angle to the arytenoid cartilage, a few fibers of it running into the airy epiglottic fold as thyroepiglottic muscle, and the ocalis muscle running from the thyroid cartilage to the vocal process. The ocalis muscle runs through the vocal fold. Now, in order to see the actions of these muscles, in order to declutter the scene, we will remove the muscles from it and just represent the muscles with arrows. Here, this arrow represents our posterior cricoarytenoid muscle. As the muscle contracts, it pulls the muscular process backwards, moving the vocal process laterally, thereby abducting or separating the vocal folds. Whereas the lateral cricoarytenoid along with transverse and oblique arytenoid pulls the muscular process forwards, moving the vocal process medially, thereby adducting or bringing the two vocal folds close together. The cricothyroid muscle pulls the thyroid cartilage forwards, thereby extending or tensing the vocal fold. Whereas the thyroarytenoid and vocalis pulls the thyroid cartilage backwards, thereby relaxing the vocal folds. This abduction, adduction, tension, relaxation of the vocal folds brought about by the action of these muscles changes the shape of the remaglottis. That is the space between the two vocal folds here. This is a remaglottis, and the shape of this remaglottis is changed. The shape and size of the remaglottis is changed by the actions of these muscles. Let's have a better view of the remaglottis. This is the remaglottis. The space between the two vocal folds is called the intermembranous part, and the space between the two arytenoid cartilages is the intercartilaginous part of the remaglottis. Now, at rest, the intermembranous part of the remaglottis is triangular in shape, as you can appreciate here, and the intercartilaginous part is quadrangular in shape. During forced breathing or deep respiration, both the parts, that is intermembranous and intercartilaginous, both the parts are triangular in shape, giving a diamond shape to the rima glottidis. During whispering, the intermembranous part is narrowed, whereas the intercartilaginous part is opened, giving a funnel shape to the rima glottidis. And during phonation, both the parts are narrowed to form a chink. And these change in shapes, which we will see next in our class, is brought about by the actions of these various intrinsic muscles of larynx. Okay, now that we got a better perspective of the actions of the muscles of larynx, let's get back to our class. So we have finished the actions of the intrinsic muscles of larynx. What is left is the clinical relevance. We will see the clinical relevance later on, along with some other clinical relevance of larynx in general. Okay. Now let's see something more about larynx. We will see the movements of vocal folds. For that, we will bring in our old picture, which we already practiced during our previous video. Here in this picture, this space here is rima glottidis. The space between the two vocal folds is the rima glottidis. The space here shown in color is the rima glottidis, the space between the two vocal folds. We already saw in the previous video on the cavity of larynx that the rima glottidis has a intermembranous part, that is the part between the two vocal folds, and the intercartilaginous part, that is the part between the two arytenoid cartilages. Okay. So the rima glottidis has an intermembranous part and an intercartilaginous part. Okay. The movement of vocal folds, which is brought about by the action of the intrinsic muscles of larynx, which we just now saw. Yes, the movement of these vocal folds brings about change in shape and size of rima glottidis. Okay. The movement of vocal folds brought about by the muscles of larynx affect the shape and size of the rima glottidis. During quiet breathing or condition of rest, the intermembranous part of rima glottidis is triangular in shape, whereas the intercartilaginous part is quadrangular in shape. Okay. During quiet breathing or condition of rest, the intermembranous part is triangular and the intercartilaginous part is quadrangular. Whereas during phonation or speech, both the parts, the intermembranous and intercartilaginous part, are reduced to a chink. Okay, they are very much narrow and reduced to a chink during phonation or speech. During forced inspiration, both parts of the rima are triangular in shape. That is both the intermembranous part and intercartilaginous part. Both are triangular in shape, giving the shape of a diamond to the rima glottidis. Okay, the rima glottidis is diamond shaped during forced inspiration. During whispering, the intermembranous part is closed. Okay, during whispering, the intermembranous part is pretty much closed, where the intercartilaginous part is open. Okay. This gives a funnel shape to the rima glottidis. During whispering, intermembranous part is narrowed and intercartilaginous part is open, giving a funnel shape to the rima glottidis. Okay. So the movement of vocal folds changes the shape of rima glottidis, and it can acquire one of the shapes discussed above. Okay. Moving on to blood supply of larynx. As far as the blood supply, nerve supply and lymphatic drainage of larynx is concerned, the vocal folds form the watershed. That is, the supply is different above the vocal fold and below the vocal fold. As far as blood supply is concerned, above the vocal folds, the larynx is supplied by superior laryngeal artery, which is a branch of superior thyroid artery, and it is drained by superior laryngeal vein, which is a branch of or drains into superior thyroid vein. Below the vocal folds, the larynx is supplied by inferior laryngeal artery, which is a branch of inferior thyroid artery, and the blood is drained by inferior laryngeal vein, which drains into inferior thyroid vein. Moving on to nerve supply, the motor supply we already saw while seeing the muscles. All the intrinsic muscles of larynx are supplied by recurrent laryngeal nerve, except the cricothyroid, the tuning fork of larynx, which is supplied by external laryngeal nerve. Okay. Coming to the sensory supply, which we will see now. As far as sensory supply is concerned, up to the vocal fold, that is, above the vocal fold, the larynx is supplied by internal laryngeal nerve, and below the vocal fold, it is supplied by recurrent laryngeal nerve. So sensory supply above the vocal fold is provided by internal laryngeal nerve, and below the vocal fold is provided by recurrent laryngeal nerve. Moving on to lymphatic drainage. Again, above the vocal folds, larynx is drained by antero-superior group of deep cervical nodes, and below the vocal folds, it is drained by postero-inferior group of deep cervical and prelaryngeal nodes. Okay, now we will move on to more clinical anatomy with respect to larynx. Some clinical anatomy points we have already seen in previous videos with the topics concerned. Now we will see some clinical anatomy in general. Examination of larynx. Okay, how we will examine the larynx. The external examination of larynx is done in a sitting position. The patient is seated in a sitting position with the head flexed, and the examiner palpates from the behind. Okay, the larynx is examined externally or palpated with the patient in sitting position, head flexed, and the examiner palpates from behind. Okay, coming to the examination of interior of larynx. The interior of larynx can be examined in a few different ways, ranging from the simpler ones to more invasive procedures. Most simpler method of examining the interior of larynx is something called the indirect laryngoscopy. which is done with the help of an instrument called the laryngeal mirror. It looks more or less similar to the dentist's mouth mirror. Okay. This laryngeal mirror is used to obtain an indirect view of the interior of larynx, and this procedure is called indirect laryngoscopy. Moving on to the next, that is the direct laryngoscopy, is done with the help of another instrument called laryngoscope, which provides a direct view of the interior of larynx. There is more advanced procedure called the fiber optic flexible laryngoscopy, which is done with a fiber optic instrument, and it requires local anesthesia, and it is done with a fiber optic instrument called the flexible laryngoscope. Next comes the microlaryngoscopy, which is more advanced, and here even tumors can be excised with the help of operating microscope attached to this microlaryngoscope. Moving on to other clinically relevant features. The infection of larynx is called laryngitis, and this causes hoarseness of voice. Laryngeal edema can cause obstruction of breathing. The misuse, or rather overuse, of vocal cords can produce nodules at junction between anterior 1/3 and posterior 2/3 of the vocal cord, and these nodules are called singer's nodules or teacher's nodules, because these are the professionals who use the vocal cords so much. Yes, so these are called singer's or teacher's nodules. Any pain in the larynx, that is the mucous membrane of the larynx, is referred to the ear, because the mucous membrane of the larynx is supplied by branches of vagus nerve. The same vagus nerve through its auricular branch also supplies the ear. So any pain in the larynx is referred to the ear. Okay. Now moving on to foreign body obstruction of larynx. In our class on the cavity of larynx, we already discussed the scenario of foreign body obstruction of larynx. We will see a few more points related to it. Okay. The larynx is the narrowest part of the respiratory passage, and as we saw in our previous video, the rima glottidis is the narrowest part of the cavity of larynx. Okay. So usually the foreign bodies lodge here. Sometimes even fishbone scratch injury of the mucosa can give the feeling of the presence of foreign body. Some of you might have felt that. Yes. When the foreign bodies lodged in the larynx or large, they block the laryngeal inlet altogether, leading to suffocation, and if first aid is not instituted immediately, may lead to death. If the foreign bodies are small, they get lodged in the ventricle or sinus of larynx, that is the space between the vocal and vestibular fold, and this causes a reflex closure of the glottis. Even though the glottis is not closed by the foreign body, the lodging of any foreign body in the sinus causes a reflex closure of the glottis, which again leads to suffocation and when not attended to may lead to death. In our previous video, we already saw a few first aid measures which can be instituted in an unfortunate scenario of foreign body lodging in larynx and causing suffocation. Yes, like Heimlich maneuver, even needle cricothyrotomy, etc. Okay. Now we will see a few other more advanced clinical procedures which are used to restore the airway. For example, like endotracheal intubation. It is commonly called intubation. Okay. It is done with the endotracheal tube passed between the right and left vocal folds. Okay. There is another thing called the tracheostomy, which is kind of permanent restoration of the airway when the airway is permanently blocked due to some growth or some other condition. The treatment instituted is tracheostomy, which is a permanent procedure to restore the airway and which involves removal of the second to fourth tracheal rings after incising the isthmus of thyroid gland and passing a tracheostomy tube into the airway. Removal of second to fourth tracheal rings after incising the isthmus of thyroid and passing a tracheostomy tube to restore the airway. The procedure is called tracheostomy. Moving on to the clinical relevance of damage to nerves. It is also the clinical relevance of the paralysis of the intrinsic muscles of larynx. The first thing which happens when there is a scenario of foreign body lodging in the larynx and causing suffocation is a severe protective coughing which tries to expel the foreign body. The severe protective coughing is a protective mechanism instituted by the body itself to expel the foreign body and prevent suffocation. And this coughing is brought about by a reflex arc of which the internal laryngeal nerve is a part. So, if there is damage to our internal laryngeal nerve, this reflex arc is broken, leading to loss of protective coughing. The left recurrent laryngeal nerve is compressed in mediastinal tumors, leading to hoarseness of voice. Okay. Any damage to the external laryngeal nerve. We saw that external laryngeal nerve supplies one muscle of larynx, that is cricothyroid, which causes tension of the vocal cord. Yes. So any damage to external laryngeal nerve causes weakness in phonation. The phonation is not lost, but there is weakness in phonation due to loss of tension of the vocal cord. If one recurrent laryngeal nerve, that is one side recurrent laryngeal nerve is damaged, phonation is still possible. The phonation is not lost because the opposite vocal cord compensates. If one side recurrent laryngeal nerve is damaged, the loss is compensated by the opposite vocal cord, and so phonation is not lost, phonation is possible, but there is a hoarseness of voice. Okay. If both recurrent laryngeal nerves are damaged, that is both right and left recurrent laryngeal nerves are damaged, phonation is completely lost because there is no movement of vocal fold. The vocal folds come to lie in cadaveric position. That is a position between adduction and abduction. The vocal cords lie in a cadaveric or death-like position, which is midway between adduction and abduction, and all phonation is lost in a scenario of damage to recurrent laryngeal nerve of both sides. Not just phonation, there is even difficulty in breathing because the opening of larynx, that is the remote glottidis, is narrowed due to the cadaveric position of vocal cord. Okay. So there is difficulty in deep breathing. With this, we will end this topic. As usual, PDF notes are available for download in the link provided in the description. If you like my classes, do hit the like button. For more such classes, keep the channel subscribed. For further online guidance, do drop a mail. Until we see in another video, thank you. Thanks for watching.